Good evening and welcome to this Nutritious sponsored symposium for OmniaMed. The topic for tonight is the GP's role in the management of cow's milk protein allergy, helping to navigate the cow's milk protein allergy consultation. My name is Vicky Evans and I'm a paediatric MSL, and it's a great pleasure to introduce our speaker today, Lydia Collins-Hussey. She's a specialist paediatric dietitian who has a wealth of experience within clinical dietetics, as well as a role in allergy research at Glasgow University. So today, Lydia is going to be sharing with us some first-line practical management of cow's milk protein allergy in a GP caseload, the identification and recommendations, and then I'll give a shorter overview of further outcomes to consider in the management of these cow's milk protein allergic infants. The presentation will last approximately 45 minutes in total, which is then followed by a Q&A. We do have lots of interest in this webinar, so please do send in your questions to Lydia and I as we're taking through your presentations. There's a Q&A box to post those questions, which will appear anonymously, and we will endeavour to answer as many questions as possible. Now over to Lydia.
Hello there, my name is Lydia Collins-Hussey. I'm a paediatric allergy dietitian and I'm here today to talk about the first line practical management of cow's milk protein allergy in a GP caseload. So the talk is split into two parts today. The first part is identifying cow's milk protein allergy, so particularly looking at allergy versus intolerance, IgE and non-IgE mediated allergy, as well as how to conduct an allergy focused history and looking at some allergy testing and when we would conduct that. The second part of the talk is in relation to managing cow's milk protein allergy, so my role as the dietitian and what that involves, as well as diagnosing non-IgE mediated CMPA, so particularly looking at breastfed babies and also formula-fed and combi babies. Also going to look at complementary feeding and weaning and when baby is ready to start solids, as well as how to introduce some of those potential other allergens into the diet. And lastly, I'll touch on the milk ladder and how we build or how baby gains tolerance. And throughout this talk, we will do a little bit of a myth-busting session as well. So to start off with myth 1, lactose intolerance and milk allergy are the same. I often get referrals for lactose intolerance when in fact it is non-IgE CMPA. And this slide just goes into the classification of allergy. So when we look at it in relation to adverse reaction to food, we either have a non-toxic reaction or toxic. Toxic being food poisoning, whereas non-toxic is either immune mediated, such as food allergy, or non-immune mediated food intolerance. And this is in relation to lactose intolerance or pharmacological or undefined. But our talk mainly today is going to be around IgE mediated and non-IgE mediated CMPA. But just to go back to that first myth, I wanted to just talk around the comparisons between milk allergy and lactose intolerance. So as I've touched on, CMPA is immune mediated, whereas lactose intolerance does not involve the immune system. We commonly see CMPA in infants, whereas it's quite rare in lactose intolerance. We will sometimes see it in relation to secondary lactose intolerance, and this is when an infant may have had a bout of gastroenteritis, or sometimes we will see it in CMPA where it's affected the lining of the gut. But this is very temporary and only lasts usually for a few weeks or so, or the exclusion only needs to be for around 4 to 6 weeks or so. With CMPA, it affects multiple different systems, so respiratory, gut, skin, whereas lactose intolerance, it tends to affect our gut. And with CMPA, small amounts can trigger a reaction, whereas lactose intolerance is usually gradual symptom onset. With milk allergy, especially IgE, obviously can be life-threatening, anaphylaxis, whereas lactose intolerance, it isn't life-threatening, although it isn't particularly nice, obviously, for the patient. So myth number 2 then, milk allergy is not as severe as nut allergy. So milk and nuts form part of what we call the top 9 allergens that account for 90% of reactions. Now, whilst peanut has this reputation of being the most severe allergen, this is simply not true. And interestingly, data from Imperial College London showed that severe reactions caused by milk or happen more with milk than peanut when looking at anaphylaxis in relation to hospital admissions. There is now a lot of awareness around peanut allergy, yet milk is seen as kind of mild, a mild allergy, and perhaps that's why it's seen as not severe, as most do outgrow it, and there's that confusion with IgE and non-IgE mediated CMPA. So let's have a look at the difference between IgE and non-IgE. So IgE is a rapid onset, so typically symptoms will be immediate or up to 2 hours after consuming milk. Typically it will be within 30 minutes or so, and it is easier to diagnose. Those symptoms are quite obvious, and we can also do skin prick testing or specific IgE blood testing alongside IgE mediated allergy. Whereas non-IgE mediated, this is a delayed onset, so typically symptoms happen from a couple of hours or can be up to days after. And this can be hard to diagnose because some of those symptoms can overlap with common childhood conditions such as reflux, constipation, which I'll go into in a moment. And it's harder to diagnose as well, is because there is no allergy testing that we can do alongside. It is a period of elimination with an introduction to confirm or exclude that diagnosis. So let's have a look at some of the symptoms. So when we look at the GI tract, the GI dominant symptoms are more indicative of non-IgE CMPA. Obviously we do see it in IgE mediated, such as nausea, vomiting or diarrhea, but we often will see a lot of our infants that present in clinic with reflux or blood or mucousy stools. They're very colicky, really irritable babies. They also may present with some diarrhea or constipation that when they're straining, but will produce a soft stool. And they also will can have faltering growth as well. And as I've already mentioned, one of the biggest challenges is deciphering the symptoms of non-IgE to those that present early in life, such as colic or reflux, teething and general illness as well. When we look at skin symptoms, undefined skin rashes can happen in non-IgE mediated, and that can be particularly hard to identify. It is a lot more obvious in IgE mediated, such as urticaria, hive type reaction or swelling type symptoms, whereas with non-IgE we still can have that redness or itching, but some of the skin symptoms can be hard to define, especially if baby has symptoms like baby acne or rashes that we just don't know the cause of. When it comes to eczema comes into both of these groups, but with IgE this would be a sudden flare, whereas non-IgE this is persistent eczema as well. What I tend to advise my patients, especially with non-IgE mediated and they're not sure about symptoms, is to take a picture so that they can show you, but also I'll signpost them to the NHS. There's a baby rashes page as well. If you just Google baby rashes, it will show the different ones, so all common conditions like chickenpox, but it also show what hives looks like, as well as baby acne and other common skin conditions as well, and it's just very useful for patients and health professionals to refer to. So in terms of the other symptoms, so our respiratory, these tend to be predominantly associated with IgE mediated. We do see some snuffly or block type symptoms or congestion are non-IgE mediated, but this wouldn't be a single symptom on its own. And then obviously we have anaphylaxis, and this is in relation to IgE mediated. So we're looking at airway, breathing and circulation. A lot of those respiratory symptoms would come into anaphylaxis. So signs include breathing difficulties, wheezing, lightheaded or collapsing or loss of consciousness. So anaphylaxis can happen without skin symptoms. And what I always refer patients to and health professionals is the BSACI, the British Society of Allergy and Clinical Immunology. They have allergy action plans that will be given out, usually in allergy clinic as well, to patients that they can refer to about managing anaphylaxis. So moving on to an allergy focus history, this is the most important part of gathering information. And there's lots of different methods out there. So for instance, different guidelines have different tools that you can use. So the International Managing Allergy in Primary Care IMAP guideline, they have questions listed in their article, as well as IACI have a toolkit. And there is something also called ETAs, which stands for exposure, allergen, timing, environment, reproducibility and symptoms. but they all fundamentally ask the same questions that I've put down here. So is there a family history of atopy? So we know if a parent has eczema, asthma, hay fever or food allergy, that can increase the risk slightly, but one of the main risks is atopy for the child. So if the child presents with eczema, especially in the first 3 months of life, then they're more likely or at risk of developing food allergy, especially if that is more moderate to severe. It's also important to the feeding history of the baby and their growth as well. So are they breast or are they formula fed? When do the reactions start? Has it been on the introduction excuse me, of solids? Also looking at the previous management as well. So eczema or refluxy type symptoms, we need to understand if what that management is and have those symptoms been under control. So symptoms, we would be looking at the type, the age, the severity. We want to know if these symptoms are either IgE or non-IgE, and if they've had a repeat exposure, so if those symptoms have appeared again when they have ingested that food. So when would we refer to secondary care? So we would refer, complex management is best provided by an MDT. So we would refer when there's severe reactions, multiple food allergy, unresponsive symptoms, allergy testing consistent with history. And quite often allergy tests aren't always done in the community. It just depends on the resource available. So it might be that you'll be referring on to allergy clinic or general peds with an interest with allergy as well as ongoing parental concern when we will refer on as well. Okay, so moving on to myth 3, allergy tests are useful in the diagnosis of non-IgE mediated CMPA. And in the case of CMPA, they are only indicated in IgE-mediated allergy. So as I briefly touched on, skin prick tests and specific IgE testing are the ones that have the evidence base and the ones that we would use. The gold standard is a double-blind placebo-controlled food challenge, but when it comes to non-IgE-mediated, there is no allergy test. And it is a process of elimination, usually for 2 to 4 weeks, with a reintroduction challenge to confirm or exclude that diagnosis. But what about alternative tests? Well, there's no evidence for these tests. They cost a fortune and they pry on the vulnerable. And what I found when patients have come to me in clinic is that they end up being on very restrictive diets with 10 plus foods, which obviously has a knock-on effect in terms of nutritional adequacy, but also can impact on child's growth as well. So it's best to avoid these. And there's a really useful food facts sheet, my registration, the British Dietetic Association. If you type in allergy testing or BDA allergy testing food fact sheet, it will bring up a really useful fact sheet that you can give to parents and discusses the ins and outs of all of these testing as well as the ones that we do use. So on to the main part of this talk today around the cow's milk protein allergy management. So we know that CMPA affects 2 to 3% of children in the UK, and it often presents in the first 6 months of life. It's rarely diagnosed after 12 months of age. So what about my role as a dietitian? So I am a community dietitian, so working in primary care, and I'm involved in all aspects of that diagnosis of CMPA to tolerance as well. So within the diagnosis, it's around allergy focused history that we've already gone into, elimination and reintroduction, but also about that nutritional assessment. So ensuring that we're getting key nutrients like calcium, iodine, vitamin D in the diet as well as ensuring little one is growing appropriately. And around that management then is breastfeeding, what type of hyperallergenic formula to use if they are being formula fed, alternative foods such as yogurts, cheese, things like that to use in the diet, as well as how to read food labels and what to look out for. And then lastly is around tolerance. So you've probably heard of the milk ladder, and we will be going into that in a little bit more detail. Food challenges tend to be hospital based. It's not my area as I work in the community. So I just wanted to touch on some of the guidelines. So many guidelines, there are many guidelines out there which can be confusing for healthcare professionals. Over the last decade, there's been so many that have come out. So you can see here that we've got the NICE guidelines, the clinical knowledge summaries, the British Society of Allergy and Clinical Immunology European guidelines. So there is a lot of guidelines out there, but the ones that we'll be focusing on today will be NICE, as well as IMAP and MAP, because IMAP is an international managing allergy in primary care guideline. They have lots of fact sheets that you can and resources that you can give to patients, as well as managing allergy in primary care guidelines. So that was the first that came out. That was a UK guideline, and then it became an international guideline as well. So myth 4, milk allergy does not present in breastfed infants. So we know absolutely it does present, but we know it's less common than in formula fed. So typically the prevalence is 0.5 to 1% in our breastfed and 2 to 7.5% in our formula fed. When it comes to breastfeeding, we actively want to support continuation, so that would be a maternal exclusion. And I've had many mums come to me in clinic and be told not to stop breastfeeding, and absolutely not. We can definitely support a milk exclusion in mum's diet. Ideally, if you've got the support there, you want to refer to a dietitian so we can support with supplements, obviously calcium, vitamin D and iodine as well. When we advise a milk exclusion or a maternal exclusion, it's usually for 2 to 4 weeks, and we would advise mum how to read labels and obviously around supplements as well. If symptoms persist, it may be that we'll be looking at other allergens to exclude out of the diet, but we need to be careful about doing this, especially because it can make mum's diet incredibly restrictive. So quite often, if gut symptoms still persist, we may take soya out of the diet, because the cross-reactivity with soya in non-IgE mediated CMPA can be up to 64% in our babies. We may also exclude egg, especially if skin symptoms or eczema is not improving as well. We might look to exclude that out of the diet. So this slide, I just wanted to show what calcium looks like in mum's diet. So calcium requirements in general in adults are 700 milligrams a day. And when it comes to calcium, when we're breastfeeding, that jumps up quite quickly to 1,250 milligrams. So this slide just highlights some of the foods that are fortified and where it is naturally found as well. But achieving this on a daily basis can be hard to achieve, as not all of these foods will be fortified either. So I usually will always advise some sort of supplement, somewhere between 700 to 1,000 milligrams a day, depending on mum's diet, and then topping up with dietary sources there. So I usually would advise a over-the-counter supplement. It doesn't have to be on prescription, and this can be bought in supermarkets or chemists, usually for a couple of pounds. So moving on to the next slide, confirming diagnosis in non-IgE mediated cow's milk protein allergy. So for our breastfed, like I mentioned, we actively want to support continuation. So we'd advise mum to exclude milk for 2 to 4 weeks, and then include back into her diet over a week, and monitor her symptoms, monitor baby symptoms. And if they do worsen, that obviously then confirms milk allergy. But if there are no symptoms, then mum can continue consuming milk, and symptoms aren't in relation to milk allergy. For our formula-fed babies, it's a similar process in that we avoid milk for 2 to 4 weeks, but they need a prescribed hyperallergenic formula. So mum, dad can't, or parent or guardian can't obtain that formula in their supermarket. They need to get a prescription for that. So after that 2 to 4 week exclusion on a hyperallergenic formula, we would then introduce a regular cow's milk formula back into the diet, and this is done very gradually over the course of a week as well. And what we would normally do is introduce it to the first bottle of the day. So as I mentioned earlier, IMAP have some really good fact sheets around this. So for instance, if baby is having around 5 ounces of formula a day, we would introduce 1 ounce of regular formula to 4 ounces of the hyperallergenic formula, and mix those together to the first bottle, and then monitor for the rest of the day. And baby would be on hyperallergenic formula for the rest of the day. Day 2, we'd increase that to 2 ounces, day 3, 3 ounces, and so on. And we would monitor to that first bottle. And if symptoms got worse, that would then confirm milk allergy. And in both cases, if milk allergy is confirmed, we advise then a good 6 month exclusion diet, and that's when we would look to start a milk ladder approach later down the line, usually somewhere between 9 to 12 months, which I'll go over in a moment. But before going ahead, I wanted to touch a little bit on hyperallergenic formula because I get a lot of questions around this. So this slide is a pictorial image to highlight the different types of protein within formula. And you can see here that whole milk protein is not suitable for cow's milk protein allergy. So this is when we start with intact protein. So these are large proteins that are made of casein and whey, and they're used in your regular first formulas. They also are in anti-reflux or lacto-free formulas as well. We then move on to partially hydrolyzed formula, again not suitable, and this is where the protein has been broken down slightly, and it's not suitable, but it's often referred to in the supermarket as comfort or colic and constipation formulas. So the ones that are suitable for milk allergy are your extensively hydrolyzed formula and your amino acid formula. So extensively hydrolyzed is a lot more broken down, usually tolerated in 90% of our milk allergic babies. So this is our first line formula that we would trial. And this is still based on milk protein, so either casein or whey. And then amino acid formula is literally the building blocks to formula. There is no milk protein in these formulas. And as I previously mentioned, these ones are on prescription. So what about hyperallergenic formula? Well, you're probably aware that it's very bitter in taste, and this is because of the type of protein, the degree of hydrolyzation, and also some of them will have lactose in them, which can make the formula slightly sweeter as well. There are common side effects with these formulas, and I often will have parents come back to me in clinic and say the stools are very green or very runny or loose, and that is a common side effect when first starting. They can also have a reduced intake as well, just while they're getting used to it and the taste, because it is quite bitter. And what you can do, especially when a baby is refusing or not taking as much, you can mix with their current formula that they were on previously. If symptoms were non-IgE mediated, then you can mix those, such as 1/4 to 3/4 and so on. It's important to note that these formulas continue to change all the time, so we'll get as evidence is emerging. So things like we're now starting to see more probiotics, prebiotics, and symbiotics, a combination as well. So just to go into the types, so you can see on this slide, we've got our extensively hydrolyzed formula, so this would be our first line choice, but it will depend on your local guideline on which one you do choose. So some are given a choice, others will have specific brands that they will be used, and this can be for extensively and amino acid formulas. So we tend to use our amino acid formulas in anaphylaxis or faltering growth, or in conditions such as esophagic esophagitis or multiple food allergies, or if there's severe eczema. If we move back to the extensively hydrolyzed formula, so some of the differences are the type of protein, such as whey or casein, if they contain lactose, if they contain pro or prebiotics, different fats. They also, both of these types of formulas, they greatly range in price as well. So extensively hydrolyzed formulas are a lot cheaper, usually somewhere between £9 to £11 a tin, where our amino acid formula are £23 a tin. So when a baby under 6 months is having around £12–13 a tin, the cost soon mounts up of these formulas as well. But local guidelines will also address kind of volumes, or should address the volumes that are appropriate, all the way up until kind of 12 months to 24 months. So what about soya formula? There's currently only one soya formula available on the market. They're not advised as a first line, and they're not advised under 6 months due to the phytoestrogen content and fertility concerns around that. But they can be considered in over 6 months if there isn't a soya allergy. But as I mentioned earlier, non-IgE mediated, that cross-reactivity can be up to 64% in our CMPA babies. In our IgE mediated, this is a lot lower, around 10 to 14% from the research. So it can be considered in over 6 months if they don't have a soya allergy and are refusing a hyperallergenic formula, but it isn't a first line formula that we would normally use. And they still contain all the nutrition as per other formulas. One of the advantages is that they are slightly more palatable in taste, and it's not something that's routinely put on prescription, as you can buy these in the supermarket and chemists at a similar price to regular formula. So I want to just move on to the next part of the CMPA journey, as it were. Many families find complementary feeding, so weaning, a very daunting time without a diagnosis of milk allergy. But it's really important to be aware of the signs of being ready and the recommendations that are out there. So recommendations say to introduce from around 6 months, but not before 4 months. So we need to be looking out for those signs of being ready, which include being able to support head and neck, able to sit up properly, have that hand-eye coordination, as well as to be able to swallow food. So that tongue thrust reflex has faded. There is a lot to consider and some really useful information out there. So I usually will signpost patients to Allergy UK. They've got a brilliant weaning pack. Also the British Dietetic Association, they have fact sheets around specific nutrients like calcium, but also milk allergy as well as patient webinars. They have a whole section around milk allergy management. So myth number 5, when starting solids, if milk is excluded, so should the other common allergens. So we used to advise no eggs or peanut until 2-3 years of age, but the evidence now shows avoidance actually helps allergy to develop. So this is based on 2 key studies that have come out in the last 5, 6, 7 years. The LEAP study, which introduced peanut into the diet of infants at high risk of peanut allergy, so those that present with eczema or egg allergy, and the EAT study looked into 6 allergenic foods, so milk, egg, sesame wheat, peanut and fish, into the diet of exclusively breastfed infants recruited from the general population. And what both these studies did is that introducing peanut and egg alongside other solids earlier, or at least by 1 year of age, may help prevent the development of food allergy. And there's a lot of prevention guidance out there now. So IACI have just brought out in the last year or so some information around this, but also the BSACI, as I previously mentioned, and the Food Allergy Specialist Group have some really good comprehensive guidelines and fact sheets for parent but also health professionals to consider what is high risk, low risk. So our high risk babies are those that have eczema or severe or certainly early onset eczema that's moderate to severe, as well as already have a food allergy as well. So how would we introduce these common allergens? Because again, this is quite a daunting time for parents. What we try to advise is to introduce one at a time when baby is well and then earlier in the day, so that we can monitor those symptoms. We always want to start small, so start with 1/4 teaspoon and then increase slowly. We want to offer them regularly, so once we know that potential allergen is being tolerated, we want to keep it in the diet. So we're ideally aiming for 2 to 3 times a week. We also want to expose baby to lots of other foods as part of developmental milestones with introducing solids. So it's important to go at baby's pace, but to continue to expose to other foods, such as those foods that are high in iron, for instance, that when stores start to drop at around 6 months of age. So moving on to alternative milk. So cow's milk is a nutritional powerhouse, and it's important to replace those nutrients elsewhere in the diet. However, these drinks do vary in nutritional composition and they are not all equal. So a common question that's asked is when can you use these alternative milks? And for little ones, we would advise that they can be used in cooking from 6 months, but not as a drink until 12 months. And this will really depend on how baby's growth is doing, how their diet, if they're particularly restricted to the diet or there's multiple allergies, it might be that we don't introduce this as a drink. It really depends, obviously, if they're breastfeeding or using hyperallergenic formula as well. So just to go into these alternative milks and how they vary, this is a really busy table, but just to highlight that no milk is 100% perfect. It really depends on each individual case. So when we look at this slide, you can see that whole cow's milk contains 66 calories per 100 mils, and ideally for energy, we're wanting something around 45 calories per 100 mils or above. And you can see that the nut milks are a lot lower in comparison to the soya or oat or pea. This is the same with protein, so ideally we want to be looking for 2 to 3 grams per 100 mils, but so you can see some of the oat milks are 1 gram, and we can replace elsewhere in the diet protein, but it's important that patient is being assessed with a dietitian as well to ensure that those other nutrients are being obtained in the diet. You'll also notice that when we look at the calcium and iodine in the middle, the oat milk doesn't have, isn't fortified, and that's because it's organic. So it's really important to ensure that babies are having, if they're having it in food or as a drink later after 12 months, that they are being fortified with calcium, iodine, but there'll also be other nutrients such as B12 and vitamin D as well, other nutrients. Cost does play a big part as well in these milks. They are 2-3 times more than your regular cow's milk there. And when the child at this age, we're aiming for around 300 to 400 mils a day. So that's nearly 3 litres a week or so that they are or potentially could be having. So it's really important that that we're aware of those more cost effective milks as well. An important tip as well is to always shake and advise around that, because the sediment drops or falls to the bottom. Myth 6, milk allergy is lifelong. So the majority of children will outgrow their milk allergy by school age, with nearly 60% outgrown by 2 years of age. And it's crucial that the dietitian is part of this process, because they are heavily involved. They provide recipes, but they also can give details around amounts and when to start as well. So the milk ladder is predominantly used in non-Ig mediated cow's milk protein allergy. It can be used in IgE mediated, but this will be guidance from the allergy team in tertiary care. So it is predominantly in those that have non-IgE where we can do the challenge at home. If you Google the milk ladder, you will find an array of different ladders that appear, but the main ones that we use are the 6-step or the 12-step, and these are based on the IMAP and MAP guideline. And the most common one that's used at the moment is the most recent, which is the 6-step. And as I've mentioned, this is usually started somewhere between 9 to 12 months, or at least 6 months from diagnosis. And the process starts with baked milk, and then we move to cooked milk, and then to purer options. So we start with foods that have been mixed with a wheat matrix, such as a biscuit or cake, as this is considered less allergenic, and then build to more cooked options, such as a shepherd's pie, for instance, and then move on to cheese, yogurt and milk itself. The amount will depend, and the guidelines do have some amounts on there, but I would always advise kind of being guided by a healthcare professional. And like I said, there are recipes to go alongside the ladder. But it's important to note to only start if patient is well, there's no illness or common colds. Thank you for listening to my presentation. I'm more than happy to answer any questions.
Now, we've just heard from Lydia regarding the identification and management of cow's milk protein allergic infants, hopefully relevant to your clinical practice and your caseloads. And for this final 50 minutes, I'm just going to walk you through some additional factors to consider in the management of these infants. So starting off by looking at the importance of the microbiome and looking at the additional benefits provided by an EHF containing symbiotics in terms of disease outcomes. And then to finish off, looking at the important considerations of taste and acceptance. Now, we've heard from Lydia that where a hypoallergenic formula is required, there's 2 categories, so the extensively hydrolyzed formulas and the amino acid formulas. And the focus of these next few minutes is specifically related to extensively hydrolyzed formulas. As we know that when breast milk isn't available, these extensively hydrolyzed formulas are often sort of the first line for mild to moderate cow's milk protein allergy in primary care, so most relevant to your caseloads. So just to set the scene then, when we're talking about allergies, it's important to look at the microbiota, and why do we target the gut microbiota with symbiotics, particularly in these allergic infants? Well, we know that the first 1,000 days are a sort of a critical window of opportunity in many aspects of an infant's development, including the development of their intestinal microbiota, which in turn then influences some longer term health outcomes. Now, we know that the gut microbiota has many important roles, one of which is programming the developing immune system. And there's evidence from numerous cohort studies that have demonstrated to us that the gut microbiota of an allergic infant is is different to that of our healthy breastfed infants. Now, this altered gut microbiota is also known as a term called dysbiosis, and dysbiosis is characterised by this sort of lower level of bifidobacteria, so our good bacteria, and higher levels of our more adult-like Clostridia and eubacteria, which are typically we'd see sort of less of in our healthy breastfed infants. They're the more adult-like bacteria, and it's widely known that our breastfed infants have the most sort of developed and diverse gut microbiota compared to formula-fed infants, so is our sort of ideal. So why does this matter? Research has suggested that gut microbiota dysbiosis in early infancy may delay oral tolerance due to some sort of disruption of immune regulation, which then in turn leads on to influence the development of other immune-related conditions. So sort of starting off with atopic dermatitis and food allergy, and then leading on to other allergic conditions later in life, for something known as, or termed the allergic march. And this allergic march then, I guess, places increasing burden on healthcare systems. So in light of this, the gut microbiota is then potentially a therapeutic sort of target for managing allergic disease. So we've seen that this window of opportunity is so important in addressing this early dysbiosis seen in allergic infants. And there's many factors that can influence this dysbiosis, and one that we can impact within this dynamic process is the nutrition that these infants get in early life. And it all sort of really starts with looking at breast milk. We know that, as Lydia's sort of mentioned many times, breast milk remains the kind of gold standard for any infant, especially those with cow's milk protein allergy. We know it's the sort of complete nutrition for infants. And as we can see from this milk droplet on the left-hand side of the screen there, breast milk contains the full composition, including prebiotic oligosaccharides, as well as healthy bacteria, such as bifidobacteria, which both support the gut microbiome. Now, where breast milk is not available and infants require a hypoallergenic formula, it's therefore important that we do consider sort of the impact on the gut microbiota and what those formulas are providing. So just a really quick recap on terminology. A prebiotic is a non-digestible fibre, so it's a microbial substrate or food for the beneficial bacteria. A probiotic are these beneficial bacteria, so these live microorganisms that can provide benefit to the host. The International Scientific Association for Pro and Prebiotics defines a symbiotic as a mixture comprising a live microorganism and a substrate which is selectively utilised by the host that confers a health benefit to the host. So as I said, thinking of them sort of having a better effect when combined together rather than a pre and a probiotic given together. So this sort of synergistic effect really provides the benefit. So looking now at some specific examples of the evidence around disease outcomes and what hopefully might be relevant to the sort of children that you're seeing in your clinical practice, what you may sort of expect to see in your consultations. And what this slide shows is some data taken from a double-blind randomised control trial with at-risk infants. So this is infants with a family history of allergy and also a confirmed diagnosis of atopic dermatitis. Although they are not, they don't have a confirmed diagnosis of cow's milk protein allergy, they do have a confirmed diagnosis of atopic dermatitis, so those potentially at the sort of start of the allergic march that we referenced earlier. And what the results showed here was that infants with IgE-associated atopic dermatitis that were randomised to an extensively hydrolyzed formula with symbiotics showed a significant reduction in their atopic dermatitis, so their SCORAD scores at 12 weeks. And interestingly, when they were revisited and followed up at 1 year, those that were randomised to the extensively hydrolyzed formula group with symbiotics for those first 12 weeks, they saw a lower prevalence of asthmatic symptoms, so reduction in frequent wheeze and noisy breathing, and also a reduction in the use of asthmatic medications in the symbiotic group versus the placebo group. So the study demonstrated that sort of potential longer term effect of taking the EHF with symbiotics, and I guess in a suggestion that there's that impact upon the allergic march, as we know that infants with atopic dermatitis typically have a higher risk of going on to develop asthma. So building on the randomised control trial, here we have a summary from a single-arm prospective study looking at the impact of switching from an EHF that either contained pre or probiotics to one which contained symbiotics. Now, this was a group of patients with a non-IgE cow's milk protein allergy, so probably very familiar sort of case study of infants that you see regularly in clinical practice. Starting at the top left, as we saw from the previous randomised control trial on the previous slide, here again we saw a significant improvement in their SCORAD scores, so reduction in their atopic dermatitis with these cow's milk protein allergic infants from baseline to follow-up, which is really important when considering the burden of such a condition. Moving on then to looking at the gastrointestinal outcomes or the GI outcomes, I think this is a really important one when we're talking about the gut microbiota, and I'm sure many of your patients present with GI symptoms. So there's always a consideration when we're introducing a symbiotic or a pre or probiotic that infants may experience changes in their GI symptoms. And what we can see from the bar charts here in the centre of the screen is that during the intervention period, so when infants were then taking the extensively hydrolyzed with symbiotics, the GI symptoms improved with exposure to these symbiotics. So there were improvements in things like constipation, abdominal pain, flatulence and burping between baseline and end point. There was also improvements in stool consistency that were observed in those in the symbiotic group, and everything was generally sort of well tolerated. What's most important to consider with these results is what the infants were on before they started the symbiotic containing EHF, and every infant within the study was already, in theory, sort of settled and well established on an extensively hydrolyzed formula that contained either a prebiotic or a probiotic. And here, where they were exposed to the symbiotics, we can see this further improvement essentially in their GI symptoms. And then finally at the bottom in the last box, there's an interesting finding, again from the same study, and one that certainly warrants some further investigation. And it was shown that children grew from baseline to follow-up, as we would expect to see of a study of this type over time. But most interestingly was that the study showed some improvements in centiles, even though there was no significant difference in the intake of formula, and they were all in theory sort of well settled and well established on their existing EHF. So what we can see during the intervention period is some sort of improvement in their linear growth when taking an EHF. Now, as I mentioned, this was sort of an incidental finding, so it's hard to conclude kind of firm things at this stage, but certainly something that warrants some further thought and further investigation. So clinical outcomes are, of course, really important, but it's also important to consider some of the more, I guess, qualitative outcomes which play a large role given the burden that allergic disease has on infants and the burden on their families also. So again, from that single-arm study with the non-IgE cow's milk protein allergic infants, what we see here is that the parental measures of quality of life related to the burden of their child's allergy were measured, and there was a significant improvement from baseline to the end of the study on for the infants that then were taking an EHF with symbiotics. So as we saw from the previous slide, there were improvements in some of those sort of clinical outcomes, so their SCORAD scores, GI symptoms, and I guess it's then sort of makes sense that if there's improvement in some of those, the kind of feeling of improvement on the symbiotic containing EHF and the quality of life then, and the impact that has on their families. Just then the final slide in this section. We've seen from the previous two slides some of the outcomes in relation to an EHF with symbiotics. That's sort of all we've had time to cover today. But in summary, I just wanted to share with you an overview of some of the breadth of evidence we have in relation to clinical findings for symbiotic containing AAF. So in the final few minutes, just to share some evidence in relation to palatability. Now, we've seen that there's some clinical and disease-related benefits for symbiotics, but I want to really make sure that we're sort of looking at the practical elements when selecting a hypoallergenic formula. Now, we heard from Lydia that where a hypoallergenic formula is required for those with cow's milk protein allergy, the EHFs are typically indicated first line where breast milk isn't available or isn't possible. Now, we know that the EHFs, as she mentioned, can can differ both in their protein sources, the addition of lactose and other ingredients such as pre, pro or symbiotics. Many of those factors will affect the palatability of the formula, which then in turn may influence the infant's liking and ability to finish the prescribed volumes. So why is palatability important? The impact can be vast. Firstly, we have the infant at the centre, so a formula which is palatable will be more pleasant to take, hopefully a more sort of smooth feeding experience for that infant, which then also directly impacts the sort of burden and stress for the families or the caregivers. And then looking more broadly at sort of healthcare professionals and the wider healthcare system, a formula that's taken well and accepted more easily will hopefully mean less formula rejection, require less need for sort of appointments and switches, a formula which then has a wider impact through less prescriptions and wasting resources. So what do we know about the taste? There was a paper by Maslin in 2018 which ranked whey-based extensively hydrolyzed formulas with prebiotics as the most palatable EHF on the market. With the introduction of a whey-based EHF with symbiotics, an independent taste study was conducted to bring the taste sort of data sort of up to date with the recent formulations. Now, this is results from a palatability study which was conducted with 102 healthcare professionals and also a group of parents. So this was 82 parents that all had infants who were less than 1 year of age. They all took part in this sort of independent blind taste test which ranked samples in terms of the overall liking, with the aim of evaluating the palatability of 5 EHFs which were all available on prescription in the UK. So they were asked to rank them for overall liking, with 1 being the most liked and 5 being the least liked. And as we can see here, overall the whey-based EHFs were the most liked, with the whey-based EHF with symbiotics or prebiotics. 95% of the HCP ranked this the most liked EHFs, as you can see here on the bar graphs, where the green and the light green bar graphs represent the EHF with prebiotics and the EHF with symbiotics. And similar results were seen with the parents, where the whey-based EHF was most preferred, and that containing symbiotics or prebiotics scored highest, so 71% of parents. And we can see here that the casein-based EHFs were significantly less liked by both healthcare professionals and the parents. And lastly then, as part of the study, the healthcare professionals and parents were also asked to evaluate a series of attitudinal sort of statements about palatability and their views about its importance. And what we can see here is HCPs believed that a palatable EHF would result in a more content families, and 88% believed it would decrease wastage and cost, which would then have an impact on the patients seen in practice. Parents felt a palatable EHF would result in, again, a number of more positive outcomes for their infant with cow's milk protein allergy, including a more, I guess, enjoyable feeding experience, more kind of content families, less wastage and less formula rejection, improved feeding durations and fewer formula switches, which have benefits, I'm sure you can agree, across both the families and the wider healthcare systems. So in conclusion then, the parents and HCPs favoured a whey-based EHF containing symbiotics and prebiotics compared to a casein-based EHF. So just in summary of everything that we've spent the last few minutes discussing. So thanks everybody for your time today. We look forward to, Lydia and I now look forward to answering your questions. Many thanks. I do hope you enjoyed those talks, and for the final sort of 10 to 15 minutes we now have some questions that have come through that we will endeavour to answer. So the first question, I think is probably one for you, Lydia, if that's okay, is what's the difference between the milk ladder and a milk challenge, and how do I know which one to do?
Yeah, so this question actually comes up quite often from patients as well, or they use them interchangeably, but they're actually different. So with the milk challenge, this is used in non-IgE mediated CMPA. So this is where we have that period of exclusion and then a reintroduction challenge to confirm or exclude that diagnosis. So that's in our breastfed babies and our formula-fed babies, whereas the milk ladder we do after we've got that confirmation of diagnosis. So we do that after a 6-month period, usually around the age of 9 to 12 months, and it's to see if there's any tolerance. And that's why we start with the bottom of the ladder with more baked foods, because we know if it's mixing with a wheat matrix and it's being heated, it's more likely to be tolerated, and then we build up in that ladder approach. So like I say, they sometimes get used interchangeably, but they are very different in their approaches on the kind of milk allergy journey, as it were.
Brilliant, thank you. That's really useful. It's really good to have that differentiation between the two. The next question here is, all of the formulas for milk allergy taste and smell different to breast milk or standard infant formula. What advice should I give to parents to help their baby move over onto the new milk?
Yeah, so they really do. And this is quite a common misconception that comes into clinic actually when they've been on a formula maybe 1 or 2 days or just not, or don't appear to be taking it. And they'll often will say that it's not being tolerated, but it's actually around acceptance with these formulas. So if it's non-IgE, we can mix the formulas. So that's what I tend to advise, to titrate them. So it may be that you can go in quite quickly, a half and half approach. But if we're really struggling with baby to take it, then it will be kind of a half an ounce or so, and we'll just increase with that. So it depends. It might be that parent is combi feeding, so we might use an express milk, or it might be that we use the hypoallergenic formula or the current regular formula as well to mix that. It just really depends on the individual circumstance for that. And what was the second half of that question? Sorry, I thought I answered that.
The second half of the question was, let me just get that up.
Sorry.
No, not at all. So obviously they do taste differently. Yeah, what advice would you give? What advice should I give to parents to help the baby move over?
If we're still struggling with titrating, quite often you'll find in practice people will use like vanilla essence, for instance, as well, just a couple of drops to mask the flavour, so good quality vanilla essence. And it doesn't need to be much at all, it's just to mask that flavour and really use in short term. You may find that professionals have used kind of a milkshake powder that's just sugar, and ideally we want to really kind of not advise that because from a dental health point of view, and obviously giving sugar to baby, but parents have used it as a short-term measure. But ideally go with titration and the vanilla essence as kind of practical tips.
Perfect, thank you. No, that's really useful. I know that's a common challenge, and it's worth getting that advice in in the first instance. Perfect, thank you, Lydia.
The earlier the better.
Yeah, sure. The next question I've got here is, how do you decide when to use an EHF, so an extensively hydrolyzed formula, or an AAF, so amino acid formula, and why?
Yeah, so this will really depend on your local guideline as well. So we would use an extensively hydrolyzed formula is the first line formula that we use, and is tolerated in 90% of what the research shows. So we would use this formula in a mild to moderate as a first line. And as I've described in the talk, we've got different ones and different properties in them. So either casein or whey based, and you may go towards more of a whey based formula. If we're struggling, especially kind of with that taste as well, because it's slightly more, in my opinion, a bit more palatable. If we have lactose added to it, makes it slightly sweeter and a little bit more palatable as well. So yeah, in terms of amino acid formula, we would only go straight to an amino acid formula if there's faltering growth, anaphylaxis, other kind of complications going on, or if eczema's not resolving, for instance, as well, or in conditions like esophageal esophagitis. Also, if the EHF is not being tolerated as well, or not, it's not being taken, then we will trial an AF then as well.
Cool, thank you, Lydia. That's very clear. I know the common challenges sometimes in those more kind of complex GI symptoms, at what point to move over to an AAF.
And that's a good point as well. Ideally, we want to kind of persevere with it. I see it quite often in practice again that we'll switch within kind of 3 to 7 days or so onto an AAF, and it's as if the EHF isn't appeared to being tolerated. So quite often in my practice, I will trial a different EHF. So if it was a whey-based one, then I'd trial a casein-based one and then move to the AAF after that. But it just depends. It's all on the individual case.
How long do you like to, do you usually recommend to persevere for before making that kind of decision to make a switch in a new direction?
Ideally, a good 10 days to a week, 10 days to 2 weeks or so, just to get, because when you move to a different formula, we get the common symptoms anyway. But it does, even if it was a regular formula, for instance, and we change it to another regular formula, we can see sometimes side effects with that as well. So it's common, I think I mentioned in the talk, around the green stools and things like that, as well as, and they can be common concerns. They want to change onto a different formula because of those. And it's just providing that reassurance and confidence around the management of these formulas and what the common side effects are.
Perfect, thank you. That's really helpful. I've just seen one comment here from one of the audience saying they've missed the beginning. Is it going to be recorded to watch back? And the answer is yes, it will be available on demand. The next question I've got here is, do most children with IgE-mediated allergy end up being referred into secondary care or diagnosed as an emergency? Otherwise, it would presumably be treated in primary care as a non-IgE without a definitive diagnosis. So any thoughts on that one?
Yeah, I think at the moment, especially with COVID times as well, we're just seeing a lot of long waiting times for allergy clinic. And quite often we know with CMPA that they do outgrow, even with IgE allergy as well, that they do outgrow that allergy by school years as well, or within kind of the first 2 years, 3 years or so. It's really difficult because it really depends on the area. We're limited with resources. It depends on local pathways, but we are seeing more kind of dietetic-led clinics now as well. But a lot of management is happening in primary care, whether that's the GP, health visitor as well. But we still need, in certain cases with IgE, that we do need some of that testing. And as I mentioned, some of it is being managed in primary care. There are nurse or dietetic-led clinics where there has been skin prick testing or specific IgE blood testing, but you still need the expertise to interpret that as well. Especially, we wouldn't advise like panel testing or, a lot of parents and carers want a kind of black or white answer when it comes to testing as well. And it isn't always the case as that. It's kind of understanding, having the expertise to analyse that properly as well.
Like you mentioned, I guess there's lots of variation across the country with different levels of resource, both in primary care and secondary care. And I know there's lots of sort of projects going on looking at kind of triaging, kind of management and that type of thing. And I guess we might see more of that in the future, which is, an interesting.
And with our non-IGs, we're certainly seeing a lot more rapid access clinics, and they tend to be led by a lot of dietitians doing that as well. So I used to work for Aviva, and they did certainly dietetic-led clinics with that as well. So it just depends, but within the NHS dietitians, or if they've got a pot of funding for that, we're seeing a lot more, because we are seeing it daily, weekly in clinics. So
yeah, I guess there'll be lots of new ways of managing it and new pathways and resource then hopefully moving forward, then hopefully can be shared. All right, let me just have a look at the next question. I believe we have a couple. Sorry, I'm just scrolling down here related to the symbiotics. So there's one, talking about, do you do a pre or a pro or a symbiotic? And the other one was what probiotic strain is within the symbiotic products, and is that different to just giving a probiotic on its own? So I'm happy to kind of cover off that one. First of all, it's a great question. There's lots of kind of, I guess, growing area of interest and research looking at, I guess, pre and probiotics. As I mentioned, we know they're present in breast milk and they have a role in the development of the microbiota and health and disease. When kind of answering this question, I always think it's maybe useful to consider looking at, I guess, probiotics more broadly. So there's an enormous probiotic market, as I'm sure you're all aware, and not all probiotics are the same. Not all have evidence or sort of proven clinical benefit within certain patient groups. And there's even a number of different strains within a species that can differ. So it's important that the clinical research is sort of specific to that probiotic strain. Secondly, probiotics, not all of them sort of available over the counter, are milk free and might not be suitable therefore with infants or children with cow's milk protein allergy. So it's important to consider hypoallergenicity and also their suitability. Not all probiotics are licensed for use in infants and children. And I guess on a broad note, thirdly, consideration, I guess, needs to be given to the sort of the dosage and the practicality and also the cost of giving an additional supplement. For those reasons that I've just mentioned, there's lots of research behind the specific probiotic strain that's within symbiotic containing EHF and AAF formulas that's been widely researched amongst a healthy population and also researched amongst that sort of allergic cow's milk protein allergy group as well. The specific strain is Bifidobacteria brave M16V is its full name, which is, as I say, lots of research to demonstrate that it's safe and effective and well tolerated, given in that sort of correct dose within the hypoallergenic formula and can elicit those beneficial changes in the allergic infant population. As I said, it's lots of research that's been specific to that individual strain to show the benefits in terms of the allergic response. And I guess from a practical side, the amount and quantity of the pre and probiotics within a symbiotic containing formula are in the right dosage to give those beneficial effects, and there's not those practicalities of adding in anything extra. And from a cost element, there's been some recent published research from a systematic review and a sort of large real world sort of cohort study, which has taken into account a cost analysis of an AAF with symbiotics versus a standard AAF, which not only highlights the clinical benefits, but also some of the results of the cost analysis demonstrate sort of wider healthcare benefits as well. I don't know if you've got anything else to add.
Yeah, no, it's really good. I mean, it's really been coming, the research with around probiotics, prebiotics, symbiotics, and there's no guidelines around it, so we're a bit restricted as healthcare professionals, but we know that the evidence is up and coming. We know that it can help with tolerance things as well. So, I often get asked kind of what ones can I use, but as Vicky's touched on, it's quite difficult, and also some of them contain milk as well. So, it depends on the child and what's happening. I can't really go too into depth there. So.
Thank you, Lydia. Yeah, it's a very interesting area and lots to consider. If you did want any more information about the specific symbiotics in the EHF and the AHF formula, please do get in touch. I think we've probably got, I know we're slightly over time, but maybe time for one more quick question that I saw come up, if that's okay. Where was it? We've done that one. With some similar symptoms, how would you determine if a baby had reflux or if it was cow's milk protein allergy?
Yeah, that's a good question. And as I mentioned kind of in the talk as well, it is tricky with our non-IgE mediated symptoms, because we know that reflux, colic, all of these are common conditions that we see in the first few months of life or the first year of life as well. So in terms of reflux as a symptom for CMPA, in my practice, I wouldn't use it as a standalone symptom. It's usually with another system, whether that's eczema or other kind of GI symptoms going on. But having said that, we do know that it can be a symptom of milk allergy. So definitely, it might be a consideration that we would trial a milk-free diet, especially if they're, in terms of kind of first line steps and positioning and other management hasn't worked, then yes, go down a milk-free diet route. Absolutely, as long as we always reintroduce to confirm or exclude that diagnosis in our non-IgE. Is there anything you wanted to add, Vicky, that I've missed there? I'm just trying to think if there was anything else. We know reflux is incredibly common, and it's around, I think the research is around 30% or so, but also just to bear in mind, especially with some of the formulas, they can be quite thin and exacerbate some of those symptoms as well. So it might be that we use a thickener alongside. It really just depends, again, on an individual basis around there.
Thanks, Lydia. No, I think that's really useful, and it's a great question because, like you said, there is that, as the question alluded to, that overlap in symptoms sometimes, and it's really about unpicking the history and making that individual assessment as to the next steps in the management. Well, thank you, everybody. Apologies if we haven't had a chance to get through all the questions. It's been really lovely to have you all this evening, and thank you so much for both your time and your engagement. Just to be aware that an email with the feedback questionnaire will follow tomorrow, and from there you will receive your certificate of attendance, which has been CPD accredited. And as I mentioned before, the session will be going on demand shortly. So many thanks again for your time tonight. Goodbye from myself, and goodbye from Lydia, and hope to see you soon.
Thanks.
Thank you.